Welcome back. Let's go ahead and dive into early stage disease. Now, early stage disease is loosely defined as stage 1, stage 2A, and then a subset of perhaps stage 2B patients. And again, too, the staging is derived from the TN and M scheme for nodes and tumor size. And I think this has already been discussed, but again, a T1 or a T2 correlates with a particular size of the tumor. So 2.5 or up to even 5 centimeters in certain circumstances might denote T1 versus T2. And this changes for every solid cancer. A T1 in breast is not the same dimensions as a T1 in lung. All right. Nodes, again, to N1 disease is typically referring to 1 to 3 affected lymph nodes. Right. And then when you see N1MI, what that really is referring to is detection of not necessarily a bona fide tumor in the nodes, but detection of a critical number of tumor cells in the nodes. So it's micrometastatic disease, essentially, right? For early stage disease, the primary treatment that's going to be recommended is going to be surgery. Right? Cold steel is the best approach to curing a patient with early stage disease. And this can be done as a breast conserving procedure or a mastectomy. And it's important to note that from a survival perspective, one technique or one approach is not superior to the other. So the lumpectomy is equivalent from a survival perspective as compared to mastectomy. It's more of a preference at this point, what the patient desires. Right? Early stage disease, small tumor, go in, remove the tumor, and then learn more about the tumor characteristics if we don't already know, and make a decision on the adjuvant treatment. Adjuvant treatment is going to depend on the tumor size. The larger the tumor in early stage disease, perhaps more aggressive that tumor is. So that might inform your decision on how aggressive to be in the adjuvant setting with certain tumors. Lymph node involvement, again, too. If you've got some micrometastatic disease, maybe we need to be a little bit more aggressive. Hormone receptor status, HER2 status, all of this informs our decisions on what to do in the adjuvant setting. Now, as far as the surgical procedure is concerned, again, the goal of a breast conserving approach is to provide the equivalent of mastectomy in terms of outcomes, in terms of survival and recurrence, but at the same time afford the patient then a cosmetically acceptable breast. And really what we're trying to do is we want to make sure we decrease the rate of recurrence. So we want a surgical removal of the lesion with negative margins. We don't want any tumor cells in the margins that have been removed around the tumor. Historically, radiation has been used after a breast conserving procedure, but this has come into question over the years, and some of the studies have revealed that the outcomes are going to be the same with or without radiation for select patients, low-risk patients in particular. There are certain individuals that actually are not good candidates or candidates at all then for a breast conserving lumpectomy. And on occasion, you may encounter a patient that has what we refer to as multicentric disease, where there is more than one primary. Or maybe you have encountered a patient that has a large tumor relative to the breast volume. So, let's be honest, breasts come in all different shapes and sizes, so do tumors. And if the tumor is large and the breast is small, it's going to be hard to perform a breast conserving procedure. That individual might be a candidate for a neoadjuvant regimen. If your patient has a history of chest radiation, perhaps they had a lymphoma in the past, they're not going to be a candidate then for a lumpectomy. If the patient is pregnant, they're not going to be a candidate for lumpectomy. And a lot of that circles around the need for radiation in the post-op setting. And then if a patient has positive margins, despite going in there and removing more tissue and removing more tissue, at some point in time, you remove so much tissue that you have to take the breast. Okay, so this is exclusionary criteria for a lumpectomy. Okay. And then just to sort of put a visual to it, if you had a lesion in the upper outer quadrant of the right breast, the surgeon can mark that tumor, go in and remove that tumor and the surrounding tissue, all right, and afford the patient with this lumpectomy. And while they're there, they might inject some dye into these lymph nodes, or excuse me, into these lymph vessels, these lymphatics. And what'll happen is that dye will indicate the lymph nodes that are closest to and then draining the tumor, and we call these sentinel lymph nodes. So we can indicate the sentinel lymph nodes with an indicator. And then what we can do is we can maybe even sample some of these lymph nodes and remove them and look to see, is there any tumor involvement in those sentinel lymph nodes? And if there's no tumor or no tumor cells or cancer cells in the sentinel lymph nodes, subsequent lymph node investigation, the second level and third level lymph nodes, is unnecessary. Opposite to the breast conserving procedure is the simple mastectomy. So you can see here, this is quite a bit larger tumor relative to the image on the left. In this scenario, this larger tumor increases the risk then of tumor spread to the lymph nodes, but the outlined area indicates where the surgeon will perform the incisions and the removal. And then again, too, this is to suggest that maybe some of these lymph nodes have been infected, so to say, with the tumor cells. So if the sentinel lymph nodes are positive, then they'll continue to look at additional lymph nodes and remove lymph nodes until such time where they feel they've gotten everything. All right. Early stage disease surgery via mastectomy or breast conserving procedure. What do we do after the surgery? What is done in the adjuvant setting? Okay, remember, adjuvant therapy implies that a surgical procedure has been done. We have measured the tumor, we have interrogated the tumor, we know the tumor characteristics, so we are informed on how we're going to approach our adjuvant treatment. And our tumor characteristics are going to be hormone receptor positive, HER2 positive, or triple negative. And then on rare occasion, I guess it's not all that rare, you might have a hormone receptor positive and HER2 positive cancer. So let's start off talking about what we do in the hormone receptor positive setting. Again, too, this is going to make up the majority of patients that have breast cancer. So we're going to spend a little bit more time on this particular setting. Hormone receptor positive adjuvant therapy, all right, largely equates to giving that patient endocrine therapy. And endocrine therapy is defined as giving the patient a drug that has the ability to either interfere with estrogen synthesis or interfere with estrogen binding to estrogen receptors. So if it's a hormone receptor positive cancer, the driver here again is going to be typically estradiol, right? So by giving endocrine therapy, we inhibit the synthesis of estrogens, or we block estrogen from binding to the receptors. What drugs do this? Well, tamoxifen or Nolvadex that you've probably heard of is a selective estrogen receptor modulator, right? And it's indicated in the adjuvant setting for in situ disease, and it's also used here as endocrine therapy in the adjuvant setting for early stage disease. So Nolvadex or tamoxifen can be used in both premenopausal and postmenopausal patients as adjuvant therapy, adjuvant endocrine therapy. Another class of drugs that is used in this setting are the aromatase inhibitors, anastrozole, letrozole, and then exemestane. These are three drugs that have been studied and approved by FDA as endocrine therapy, and they're used in the adjuvant setting for hormone receptor positive breast cancers. Right? Now, aromatase inhibitors by themselves are typically reserved for postmenopausal women. They work well, but they only work well when the ovaries are no longer synthesizing estradiol. Right? Now, in a premenopausal patient, the ovaries are the primary site for estrogen synthesis. Well, once you get to menopause and you're postmenopausal, the ovaries typically shut down, and the majority of estrogen that a female patient has is being produced either by adipose tissue or the adrenal glands. And aromatase inhibitors do a good job of inhibiting estradiol synthesis in either of those sites. But the aromatase inhibitors can't overcome estrogen synthesis driven by the ovaries. Right? Now, if you want to use an aromatase inhibitor in a premenopausal patient with intact ovaries, which you can do, and it's been studied and it's been shown to be effective. However, if you're going to do that, we have to also inhibit ovarian synthesis, and we do that with ablating the ovaries or we give ovarian suppression. Sometimes removing the ovaries, bilateral oophorectomy is done. Other times they can use an LHRH agonist. All right. So those are a couple strategies that are done. So again, just to recap, endocrine therapy, what is it? Using an antagonist or using an inhibitor of estradiol synthesis. All right. All right. I'm running out of time on my Zoom, not that you needed to know that. When we come back, we are going to pick up with our discussion on treating early stage disease, hormone receptor positive. Talk to you soon.